Good afternoon, ladies and gentlemen. Welcome again from Prague. I'm here today for the whole afternoon with my colleague Peter Peichl, and we will moderate today's sessions. I hope that you enjoyed yesterday live cases, you enjoyed yesterday's discussions and presentations. And we have today also exciting two blocks. One will be dedicated to some new strategies in ablation of atrial arrhythmias. Then we will see two live cases from our lab in ICAM. And then finally, we will have a session which is dedicated to cardio-neuroablation, which is one of the greatest advancements in catheter ablation, not arrhythmias, but catheter ablation of neurocardiogenic syncope or functional bradycardias. So, saying that, I hope that you enjoy today's afternoon, and we start with the first session.
Hello everyone, and thank you very much for the invitation to talk to you today on non-contact mapping, state-of-the-art, and show you a live case, which we did a couple of weeks ago. So my name's Tim Betts, and I'm an electrophysiologist from Oxford at the University Hospitals there. And I'm basically today going to be talking to you about the Acutus mapping and therapy system. So the Acutus system is a non-contact mapping system which comes with amplifier and the basket array and the console and workstation. But they've also acquired a gold tip irrigated ablation platform with contact force sensing, which I'll also be using throughout the case. So just to summarize the AcuMap system, the basket is incredibly novel. It's 2.5 centimeters wide when it's expanded. It has 6 splines, and on each spline is 8 electrode recording electrodes, as well as 8 ultrasound transducers, which are used to create the anatomy and geometry. So step 1 is to create chamber geometry by gently rotating the basket inside the left atrium in this example, collecting over 100,000 points per minute. A whole chamber geometry normally just takes 1 or 2 minutes to collect, and then a little bit of post-processing. The other novel aspect is the non-contact mapping itself. And this is where the 48 electrodes sit in the center of the cavity and detect unipolar far-field voltages. Now, the unique thing about this system is rather than trying to reconstruct electrograms and timings and activation from voltage, it does more calculations to create charge density, which is a more accurate way of examining the wavefront propagation and localizing it and getting the correct timing. This has actually been validated, and this is a recent publication in JACC EP, which looked at patients who had both atrial fibrillation and sinus rhythm and compared the non-contact mapping of Acutus to a circular mapping catheter contact electrograms. It looked at both unipolar electrogram reconstruction and consistency and correlation, as well as timing. And it found that in both sinus rhythm and in atrial fibrillation, there was excellent morphology correlation, as well as very good timing correlation in both sinus rhythm and atrial fibrillation. It is somewhat distance dependent, and if you get more than 4 centimeters from the wall of the chamber, the resolution drops off. But with it positioned in the center of the chamber, it's very rare for that to happen. Now, when the propagation maps are calculated, This is the sort of thing which you would see played back at a slow sweep speed. So this is the left atrium in an AP and a PA view. The red color is the actual front of the wavefront of depolarization, and the colors behind it just show the history of that wavefront's movement. The faster the wavefront, the more wider spread the colors. Now, this is one of the phenomena which we look for, rotational activity. And you can see in the left-hand window, there's a clear sort of clockwise spinning going on in this. This is just one recording of about 5 seconds worth of atrial fibrillation. It's very localized. Here's another example with a 3-second recording of atrial fibrillation. And this one is on the right-hand window on the posterior wall below the left inferior vein. And you can see a counterclockwise rotation. And it's interrupted occasionally by other passing wavefronts, but spatially it's relatively fixed. And sometimes, to get even clearer pictures, we give a big bolus of adenosine to get rid of all far-field QRS electrograms from the sensing of the ventricular activation. Now, there is a QRS and T-wave subtraction algorithm which does this pretty well anyway, but if the ventricular rate's quite fast, giving adenosine is quite helpful. And again, we've put some helpful circles on there for you so that you can get your eye in and see that rotational activity, which is coming and going at a spot on the anterior wall, as well as the other more chaotic wavefronts. Now, another phenomenon which we will sometimes see and will look to target is focal firing, which, as you'd expect, shows a radial centrifugal spread from a spot in the atrium. And here you can see in the mitral isthmus here, laterally in the right-hand window, there is quite clear, repetitive focal firing coming from pretty much the same area each time, subtle variation. And then the third phenomenon which we look for as a potential target is localized irregular activation. And that's defined as areas where there is sudden slowing, pivoting, turning of wavefronts, but not a full rotation, and breaking up into daughter wavelets. And there's definitely a body of thought which thinks that this phenomenon is responsible for the perpetuation of fibrillation rather than rotational focal firing. Here's another example. And sometimes we see these irregular areas at sites which also have occasional rotation or focal firing. And if you just get your eye tuned into it, you can see that on that posterior wall below the left inferior vein, the wavefront is held up, it's often twisted, turns, pivots, or breaks into other wavefronts. Now, there's also another mapping possibility called Supermap. And this is what we use for regular tachycardias. I'm just going to reverse back. There we go. So with this, when you have an organized regular tachycardia, you move the basket catheter gently around the chamber, not having to touch the walls, but getting close to all of the walls. And as we get a high density of recordings, the chamber is colored in pink until you know you've got a global map. What it's doing is taking a global non-contact map of each beat of tachycardia and then just recording another and another and another and superimposing them all on top of each other to give a very high density, accurate map of the organized tachy. So it takes about 2 to 3 minutes to collect a whole chamber map. We then select the bin of cycle lengths, which we think represents the tachycardia and eliminates any ectopics or wobbles, and then play it back as a single beat. And this is something you'll be more used to seeing as a propagation map with Carto, precision, or arrhythmia. And in this example, what we had was a roof-dependent left atrial flutter. You can see it going down the anterior wall and up the posterior wall. So we've learned some things from mapping over the last few years using this system. So the irregular activation is spatially really quite stable. In this study, when we looked at 2 sequential 30-second recordings and were able to plot the frequency of these phenomena, in the left-hand window, you can see in the purple and blue that irregular activation was very commonly seen on the anterior wall in that blue band in both the first and second recording. However, rotational activation in the middle window and focal activation in the right-hand window the area where it was most frequent in recording 1 was often different from the site where it was most frequent in recording 2, showing that those two phenomena don't have much spatial stability over time. That means that to detect areas which are happening frequently for focal firing and rotational activity, you need longer recordings to try and tease them out, whereas this irregular activation, which presumably represents the underlying substrate such as scar, fibrosis, anisotropy, and complex fiber orientation, is very spatially fixed. Now, I mentioned that we give adenosine sometimes to clear away the QRS complexes, but what does that do to the actual atrial fibrillation electrophysiology? Well, we did some pre and post adenosine recordings in patients in atrial fibrillation, and what we found was adenosine doesn't affect focal firing or irregular activation, but it does increase the number of rotations which you record over a segment, not necessarily increasing a single site's frequency of rotation, but dotted all around the chamber, the total number of rotations increases. This has also led us to discover a little bit more about the different phenomena in different types of atrial fibrillation and started to get into phenotypes. So irregular activation can be found equally in persistent or paroxysmal AF, also whether the patient comes in sinus rhythm and has it induced or has been in AF when they enter the lab. Rotational activation is seen more frequently in persistent AF and in people who come into the lab in AF, which will go hand in hand, whereas focal firing is more common in paroxysmal AF and AF which needs to be induced. And there's an inverse relationship between the two, so the more rotational activity there is, the less focal firing, and the other way around. So, in our experience of almost 150 of these cases now, we get some patients where, with our first maps, we can see a very driver-dependent sort of organized AFib, where there's clear repetitive focal firing and rotational activity, and a clear target which we're going to aim at for ablation. But we also get some patients in whom our maps, and we study them again and again and record segment and segment, show chaos. And it's very unusual to see the repetitive phenomena, rotational focal firing. And so, are these people beyond ablation, or do they need a different approach, targeting the irregular activation or doing a more classic segmental box isolation or linear lesions? And of course, we shouldn't forget the right atrium. In a number of cases, having got rid of what we believe are drivers in the left atrium, we map the right atrium. It only takes a few minutes to do the geometry and then do some 30-second maps. And as in this example here, we found an area of repetitive focal firing in the lateral cavo-tricuspid isthmus area, and targeting that restored sinus rhythm. And certainly those patients who need cardioversion at the end of ablation are often those in whom the right atrium has a large proportion of rotational activity and other phenomena than those who, when we're just doing left atrial ablation, spontaneously go back into sinus rhythm. So there's definitely a proportion of people in whom the right atrium is a significant contributor, and this is a very easy technology to use to map that. So what clinical experience is there? We're starting to get publications, multi-center publications. This is the Uncover AF trial of 125 first-time persistent AFib patients in a registry who were treated with the AccuMap system. And you can see a very good, over 70% single procedure success rate from freedom of AF, 70% freedom of all arrhythmias at 12-month follow-up. We don't have any randomized trials, but this has recently been published by the Brompton group, with ourselves contributing as well, and it's propensity matched. So in 40 patients treated with Acutus for first-time procedure, we use the quarter boundary approach. So this is undertaking a map, doing PV isolation, remapping, and then targeting these most consistent phenomena, rotation, focal firing, with a cluster of RF lesions, and then joining that up either to an isolated vein or the mitral annulus, and targeting these phenomena until either we got sinus rhythm, which in fact a large majority of patients we ablated for sinus rhythm, or felt we'd treated enough. We compared this to 80 patients propensity matched the persistent AF who underwent PVI and posterior wall isolation. And you can see that our single procedure success rate was higher with this individualized acutus-guided approach than an empiric approach. So to summarize my presentation, non-contact mapping with AcuMap, it can identify these complex patterns of propagation. It's very easy to do a map and a remap approach, and I'll talk about that in the case presentation. And we're beginning to individualize our approach, which I think is what needs to be our solution, because no empiric approach has yet been shown to be superior for persistent AF. And so the quarter boundary of ablation of these phenomena is the current approach which we're using with this system. Don't forget, we do have Supermap, which is actually a joy to use when it comes to irregular atrial tachycardia, because it's very quick to get global mapping. And of course, don't forget the right atrium. So now I'm going to move on to our live case in a box. So this is a case done here in Oxford just a few weeks ago, specifically for this meeting. We were hoping to do it live, but this is the next best thing. So it's a 55-year-old gentleman, recurrent persistent AF, who had tachycardic cardiomyopathy, but following the cardioversion, his ventricle improved. He's relapsed. He's back in AFib and had been in AFib for 2 months prior to this procedure. So here's the system. As you can see, we've got AcuBlate and Acutus. It's not yet integrated into one system. There is the Acutus basket catheter. So following my transseptal puncture, I switch over to the steerable Acutus navigation catheter, put the basket catheter in through that into the left atrium, and then that's the AcuBlate ablation catheter with the gold tip. The basket's in the middle of the chamber there, and there's a temperature probe. So we start off by doing the chamber geometry. So this is just gently twisting and rotating the basket inside the left atrium. The 48 ultrasound electrodes are beaming out thousands of ultrasound beams. And if you get different angles, you get different lines of sight into the veins. There's a little bit of post-processing to smooth it over, do a valve cutout to help orientate us around the anatomy. But this whole process takes no more than about 3 or 4 minutes to do. And there's been a good correlation with CT geometry. You don't see much of the veins because, of course, they bend and twist and the ultrasound beams don't get around there. But you can do more traditional impedance-based contact geometry with catheters if you want to add to them. So then we do AF mapping. So the catheter just sits in the middle of the chamber. We will record a 60-second segment, but we'll then play back and analyze 10-second segments, but maybe look at 1 or 2 during that 60-second recording. Now, this is going by quite fast, but just look in the AP in the left window, PA in the right-hand window, start to get your eye in as to what might be going on, looking for twisting, turning, focal firing. So we'll go back over this more slowly later on in the video. So we've got lots of chaotic wavefronts from atrial fibrillation, but if you look on the right-hand window, on the top of the posterior wall, we just have 3 rapid focal firings. And in fact, there's quite a lot of focal firing from the roof. In the left-hand window, anterior to the where a roof line might be, just left to the appendage, you can see there's quite a lot of twisting, irregular. It's an area where the wavefront stops and twists and breaks and is occasionally rotating. Now it's slowed down. In that left-hand window, you can see that area on the front wall, which seems to cause twisting, functional block, rotating. It's quite localized. On the back wall, you can see the slow focal firing. This is really slowed down just to help emphasize it. And we've animated some red dots there to give you some warning the focal firing just about to come, so you can look at that. Now, the more of these you see, the more used to it you get, but we'll often play a 10-second segment through once or twice and really go by eye initially to see what stands out, what's consistent, what's happening the most. There is an algorithm called AcuTrack, which is in the top there, which uses color coding to highlight these features. And the pink on the roof there is telling us that there's a very high density of focal firing in those vertices at the top of that geometry. We'll then look at another 30 seconds. We have to work out another 10 seconds, a hierarchy of phenomena. You know, what are we going to target first? And so we'll look at this 10-second recording from later on in that 1 minute segment. And we have the same thing, that twisting, turning, rotation happening on the anterior root, and quite a lot of focal firing or just behind it. So that's definitely an area of interest. But as with all AF ablations, we'll start off with pulmonary vein isolation. We can just do that guided by the anatomy. Often might swap out for a circular catheter to show that we've got PV isolation. We use 30 to 40 watts with the gold tip catheter. And in this case, we got PV isolation. Then we'll switch back with the acutus catheter and do yet another map. And then this time we used adenosine. So we had a really nice long segment. And even in this map, we're seeing that same area really driving the atrial fibrillation, or at least we believe that's what it's doing. So we targeted it, core to boundary, did some ablation in the mid-roof and extended it to the left upper vein. And during that, it organized into irregular tachycardia. So as soon as that happens, we do a supermap. And as I mentioned, we rove the catheter around the chamber and collected about a minute or two's worth of tachycardia. So that's going to be about 400 beats all superimposed on top of each other. And now we're playing back that single propagation map of a single beat. And what you can see is this tachycardia starts in the low septal left atrium and spreads uniformly from septal to lateral. And actually what this suggests is that it's a right atrial tachycardia. But as often happens, within 2 minutes, he degenerated back into atrial fibrillation. So actually, it was very useful to have got a very quick map, super map. And we, of course, we had no time for entrainment. We were back in AFib. So we did another AFib map, another 60 seconds of mapping, and then looking at a 10-second segment. And here you can see that there's a definite area of interest of rotation, slow conduction, happening just below the cluster of lesions that you've already put in. So a decision was made to extend that lesion set down to that area to see if we can transect this, and then join it up to the right superior vein, because we've done quite a lot of ablation there. We don't want a roof flutter. And actually, during that lesion set, the AF terminated. So when that happens, we want to check that we've got a block in our roof line. And that's easy to do by putting the ablation catheter in the appendage, pacing, and then doing a supermap by roving the basket around the back wall. Again, it only takes about a minute or so to collect the number of points we need to do that. We have to do a little bit more processing to make sure we're eliminating the pacing spike, which gets detected very early, and the QRS. And we're just going to look at the segments, which 95% of the beats which we collected were analyzing, and look at the propagation. So when we play that forward, you can see the pacing from the appendage. It goes down the anterior wall and then all the way up the posterior wall from low to high, showing us that we have a complete line of block across the roof, as well as ablating that area of rotation and focal firing. Now, we did have that proximal to distal coronary sinus tachycardia. So we thought we ought to do a cavo-tricuspid isthmus line, just to be sure, on the way out. Now, we could have just done this empirically, just with the ablation catheter and no mapping. We could have pulled the basket catheter back and done an ultrasound geometry, but the acutus system also has a much more conventional impedance tracking system for creating geometry and for doing 3D electroanatomical mapping. So this is me just moving the circular mapping catheter around, tracking it with the acutus system, and building up an activation map whilst performing proximal coronary sinus pacing, like you would with a Carto precision or arrhythmia system. And you can, of course, you can switch from one module to another at any time. Sometimes you can use this as a way of assessing linear block. Here we're just playing the propagation map over the isochronal map, and you can see that before having done any treatment to the right atrium, coronary sinus pacing travels through the isthmus and also up and around the septum. So then I did a CTI line using the Activate catheter. We repeated a quick color map, and we could see that there is conduction block in the isthmus. It's now having to rotate its way all the way around, everything which is you're familiar with. But as you can see, it does give you a nice contact map if that's what you need. And then we confirm that also just by doing our standard electrogram timing in the ablation catheter next to the line and up against the lateral wall. So to summarize, we've isolated the pulmonary veins. We just went back and checked those and demonstrated exit block when we get capture. And then during the roof focal ablation, and which we subsequently extended to a linear lesion, we got some transient organization. And then actually, rather than ending in a stable flutter, we went straight to sinus rhythm. But we did the CTI line in. And that whole case from start to finish took about 2 hours. Thank you very much.
Hello to this lecture. First of all, I would like to thank the organizer for the kind invitation to participate in this classical meeting now. So my task for today is to discuss with you high power short duration ablation for AFib. And this is the acronym, and these are my conflicts of interest. When we speak about AFib ablation and how to improve AFib ablation, first we have to consider aspects of efficacy. And we know that efficacy for paroxysmal atrial fibrillation is in the range of 65% freedom of atrial fibrillation at 1 year with RF or with cryo. These numbers, this is from the finalized trial, and these numbers have been improved recently in other trials, like in the CIRCA dose, so roughly 80% freedom of atrial fibrillation recurrence at 1 year. However, one of the criticisms of the procedure is that still there is some improvement needed, especially not probably to have more durable PVI, and also especially for RF in terms of shortening the procedure time. Another important aspect that we have to consider is safety. AFib ablation is nowadays a safe procedure, but still there are some complications that are really worrisome, like this one that all electrophysiologists are afraid of it, that is atrioesophageal fistula. This complication has been reported in the past for RF ablation, but also for cryoablation. So this has led that many of us have reduced power when ablating the posterior wall in order to reduce the chances of this complication. So how can we improve these aspects about efficacy and safety with high power short duration application? And to learn this, or to try to decide if this can improve or help us, we need first to understand the basis of RF current. And we know that standard conventional RF application produce two types of different heating. The first one is resistive heating, that is produced by the direct effect of the RF current flowing through the tissue. From this heating area of resistive heat, there is a secondary phenomenon that is conductive heating. So you have these two components. What is then conventional RF application? Here you can see some series of recent series of AFib ablation with the different powers used in this in them, and you see that most of them power was around 25 to 30 watts. So any value above this 25, 30, 35, 40 even should be considered high power application. And what is the could be the rationale to use high power short duration? The rationale is shown in this slide. So with high power and short duration, the intention is to favor resistive heating and have very little conductive heating. This first will result in a more rapid lesion and more, so less time needed to create lesion, and also in a secondary effect, it may have benefits in terms of damage of collateral organs. This has been studied recently in animal and in vitro models. You see that the lesions were similar or even smaller when using high power and short duration compared to conventional here on the right of the slide. But same side not necessarily means same shape. This has been also studied, and you see here that in general, in this, at least in this study, a standard RF application resulted in similar volume compared to high power short duration, similar volume around 272 millimeter. And you see, but despite this similar volume, standard application resulted in deeper and narrower lesions compared to high power short duration that were wider and shallower. With this, all this in mind, we conducted a study some years ago that was called the Fisteso study, and we included 32 patients with paroxysmal atrial, mostly with paroxysmal atrial fibrillation. We conducted an ablation by point-by-point RF application, and we used two esophageal probes in order to detect increases in temperature, in esophageal temperature. One was a conventional one and one was steerable. And this was more or less what we did when an increase of temperature was detected. We apply a second application with the same setting just to see if there were added effects in the temperature. But the third application that we delivered was with a decrease of power with extended time in order to see if this was resulted in less temperature increase. And here you see the results. I am only showing you the differences between the first and the second application. And you see that the differences in esophageal temperature were in favor of high power. So the applications with lower power resulted in higher temperature. But more importantly, it was not only the amount of the peak temperature, but also this lasted longer. So eventually, or ultimately, could result in a more aggressive injury to the esophagus. After this study, we decided to conduct the PowerFast study. There are a series of studies. The first one was published in 2 years ago. We included a control group of conventional ablation, 20 watts and 30 watts and 20 watts in the posterior wall. And this group was compared with a high power short duration. In the first patients, we used 50 watts guided by LSI or ablation index. But in the last patients, we used 60 watts. All patients had an esophageal endoscopy taken in the following days. And you see here the results. In terms of efficacy, you see that the high power short duration group resulted in more first pass isolation of the veins. Complications were similar. And in terms of esophageal lesions, there were less lesions in the high power short duration group. After that, a group from Germany, Isabel Eisenhower, published a similar study comparing conventional ablation, now using high power short duration with 70 watts. You see the results have 1 year follow-up with more freedom of atrial fibrillation in high power short duration group. More recently, we have also performed another study comparing 70 watts, not only 60. Again, esophageal endoscopy, not all of them. And you see that in terms of efficacy, there was a trend that was significant in the left pulmonary veins to higher first pass pulmonary vein isolation with high power short duration application using 70 watts. In terms of safety, again, no lesions detected with 70 watts, so appears to be safe. This is the kind of lesions that are created in general, and these are automatic lesions. You see that they are very clean, so you can conduct a very rapid and consistent procedure because you don't need to have the catheter there for a long time. You just need to have the catheter for a couple of some seconds there, so it's easier to have to achieve your goal. More recent data is the very high power or ultra high power short duration type that I will talk to you in a moment. But a more recent study has been conducted. It's a meta-analysis of all species. And you see here that also our study was included. You see that in terms of atrial fibrillation freedom, interestingly, we can discuss this. Conventional RF appears to be superior. However, for acute recognition, high power short duration was superior. For complications, they were similar. Procedure duration was much better for high power short duration. And this is the study that I was referring to. That is the Q.FAST trial using very high power short duration approach. This, of course, needs a special catheter with microelectrodes. And in this study, the settings was using 90 watts delivered during 4 seconds. So very high power. This study has no long-term results published yet, but has some information from the initial study as the total procedure time that is significantly shorter than with conventional ablation and other parameters as well. So in summary, ladies and gentlemen, take some take-home messages. High power short duration appears to be safe and effective. Reduction of this results in a reduction of RF and procedural time, what is important. And finally, we still don't know the best settings to be used, or if we need to adjust power according to different left atrial areas. Like, for example, if you are ablating close to the backbone bundle, or if you are in the posterior wall. So this is something that will need to be clarified in the near future. Nothing else. I will show you soon the Life in the Box video with all these concepts shown live. Thank you for attention.
High power short duration AF ablation in a patient with an atrial septal defect closure device. This was a 40-year male patient without risk factors who in January 2020 developed acute pericarditis and atrial fibrillation. He had ostium secundum atrial septal defect large, which was closure in March with an ablation device. However, 1 month later he developed again palpitation, atrial fibrillation was again documented and was terminated with flecainide. The patient was discharged on flecainide, but despite this drug and amiodarone later, the patient continued to have atrial fibrillation episodes. Finally, he was scheduled for atrial fibrillation ablation, PVI, with high power short duration RF application. The plan was to introduce a CS catheter, a screening catheter in the septum, and contact-sensitive catheter for ablation. The procedure was guided with inside precision 3D mapping and TE and ICE. The idea was to perform a transseptal puncture guided by fluoroscopy and TE, and mapping was planned with the ablation catheter once the device was crossed. Later, this catheter will be replaced by a PV catheter in order to check the pulmonary vein electrograms. Finally, high power short duration will follow. This patient was similar to others that we had several years ago, with a large device that was including all the septums. So we needed to cross the device. The peculiarity is that you need to puncture the device not in the peripherum, because you will need to cross 4 layers of wires, but not only in the peripherum, also you need to avoid the center of the device where all these wires collide. So we started the procedure guided by TE, and you see that the device was crossing the septum. Then we performed the typical technique and tried to puncture the device. However, the needle crossed easily, so you can see in TE how the bubbles appear once the needle has crossed the device. However, when we tried to push the sheath, we found a high resistance, and it was impossible to cross the sheath towards the left edge. So we decided to remove the transeptal sheath, place a dilator of an Eiley sheath, that is an air French. With this we dilated the device, and then it was now easy to cross the device with the transeptal sheath. Once in the left atrium, the ablation catheter was introduced through the sheath, and then we developed a 3D map of the left atrium and the pulmonary veins. The catheter moved freely, however, due to the stiffness of the septum, it was difficult to go to the right-sided veins. Then we introduced the PV catheter, mapped all 4 veins, and we left some shadows in order to then be sure where the electrograms were recorded of the veins. You see that in all 4 veins we were able to find electrograms. Then we started with high pulse rotation RF application. So these are the settings planned, 70 watts for 9 seconds, although the first 2 were ramping up of power. We started with the left pulmonary veins in the carina, and you see the green numbers reflect the power delivered for 9 seconds. And point by point we were moving the catheter around the left pulmonary veins, again 70 watts for 9 seconds in each side. We were moving all around the vein with the same settings, regardless if it was the anterior wall or the posterior wall of the veins. The settings are always the same, 70 watts for 9 seconds. Once the left superior pulmonary vein was anatomically isolated, because the pulmonary vein catheter was not in place, single transeptal puncture, we started with the left inferior pulmonary vein with the same approach, 70 watts per 9 seconds in each side. After anatomically isolated, we moved the catheter to the right-sided veins, started in the posterior carina, again same settings, 70 watts for 9 seconds in each side, irrigation 70 ml per minute, and started with the posterior carina and moved to the anterior carina, and then around the right superior pulmonary vein. These veins in the anterior part were easily reachable, so this part of the veins of the right superior pulmonary vein was easily ablated. However, when the catheter was moved to the right posterior wall, due to the progression of the sheath in order to avoid losing the transeptal and the stiffness of the septum, it was really tough to have a direct approach to the posterior wall of the right side veins. So we needed to loop the catheter, and this created some difficulties in order to have a continuous line of lesions, and the catheter was jumping back and forth all the time. Eventually, the right superior pulmonary vein was anatomically isolated, and the plan was to continue with isolation of the right inferior pulmonary vein with a similar approach. Again, the same settings, 70 watts and 9 seconds were used in both the anterior and posterior wall of the right side veins. So now here we start with the right inferior, posterior wall, and move the catheter all around the vein, try to have continuity of lesions. Anterior wall, again 70 watts, the green numbers reflected, 70 watts again solely for 9 seconds. Once the veins were thermically isolated, we checked with the pulmonary, with the ablation catheter. There were electrograms in the left side veins. You see there are no electrograms and no capture, no apparent capture. So again, left inferior pulmonary vein, no electrograms, we paste, and no conduction from the spike to the CS. However, this was not the case in the right side veins. In the right inferior there were electrograms and there was a capture of the atrium while pasting there. And the right superior had a distinct electrogram. We found a gap in the right inferior pulmonary vein that was isolated, and after that the electrograms were lost. And for the right superior we had a map, quick map of activation, and the gap was found in the carina, where several lesions were delivered, and after closing this gap in the carina, the electrograms were lost. However, we wanted to check better with the PV catheter, but the sheath did not advance, so we needed to place again the wire, and over the wire with the dilator we now were able to cross the septum again and place the multipolar catheter to have a more precise mapping of the veins. We took the catheter to the saddles, the previous saddles, in the right side and superior and inferior veins, with no electrons unless we paste, so with local capture without exit conduction. Then we took the catheter to the left pulmonary veins, left superior pulmonary vein, same place that before, with local capture with exit block. Here you see how there is a far field electrogram that is not captured by our pacing spike. Final result, so despite that this was a complex procedure, it was easily done with high power short duration RF application. So thank you very much for your attention.
This is Takanori Yamaguchi from Saga University, Japan. My presentation today will be on ablation of low voltage areas in persistent AFib. This is my COI. So first, low voltage area LVA, traditionally defined as less than 0.5 millivolt in the left atrium, is a strong predictor of AFib AT recurrence after PPI. Many previous studies have reported similar findings. LVA has been considered as a surrogate of fibrotic tissue and would be a marker of AFib substrate. On the assumption that LVA would work as a AFib substrate, several researchers, including our group, have reported the efficacy of substrate modification based on LVA. We homogenized LVAs as shown in these figures. Other researchers have reported similar results. Rolf et al. Reported linear ablation across low voltage area and isolation of low voltage area. Kottkamp et al. Reported box isolation of LVA, and Yan et al. From Nanjing reported LVA homogenization and the dechanneling of narrow isthmus. We also reported that LVA extent predicts ablation outcomes even after LVA homogenization. We defined stage 4 as more than 40% of LVA, and the stage 4 patient had poor ablation outcomes even after LVA ablation. However, I have wondered about whether low voltage area reflects local fibrosis or diseased tissue, and whether non-low voltage area reflect healthy tissue. To answer these questions, we analyzed the relationship between low voltage area and mean LA voltage. To measure mean LA voltage, high-density voltage map was created using HD grid during right atrial appendage pacing, and LA was subdivided into each 1 square centimeter area. Mean LA voltage was calculated using the highest voltage of each sub-area in the full LA. In 140 patients were analyzed. 140 patients were analyzed. Patients were ranked based on mean LA voltage from lowest to highest, and divided into quartiles, Q1, Q2, Q3, and Q4. Q1 is a group of the lowest mean LA voltage, and Q4 is the highest group of highest voltage. Interestingly, buoy mean LA voltage by patient was stratified along a continuum ranging from 1 millivolt to 12 millivolt. There was a more than 10 times difference. And we evaluated LVA using 3 different cutoffs, 0.5, 1.0, and 1.5 millivolt. Then the presence of LVAs was compared between quartiles. At any voltage cutoff, LVA was more frequently identified in Q1 and less frequently identified in Q4. And this is a yellow shows low voltage area defined as less than 1.0, and the red bar shows low voltage area defined as less than 0.5. LVA 0.5 was not identified in Q3 and Q4. This data suggests that while individual LVAs represent localized voltage reduction, the presence of LVA reflects the global voltage reduction. We also evaluated mean regional voltage in the anterior wall, septum, roof, inferior, posterior, lateral of the left atrium. At any region, regional voltage in Q1 was lowest, and in Q4 in Q4 is highest. And this data suggests that voltage reduction is a diffuse process in the full LA. In addition, regional voltage of the anterior and septum were consistently lower compared to inferior posterior lateral wall, suggesting that even in quartile 4, anterior wall voltage in the anterior and the septum is lower than posterior and the lateral wall, and suggesting voltage of the anterior and the septum is lower than that of posterior and the lateral wall by nature. And this can explain why LVA is more frequently identified in the anterior and the septum at any voltage cutoffs. This figure shows the relationship between the extent of LVA and mean LA voltage. When LVA extent increased, mean LA voltage linearly decreased at any voltage cutoff. In this figure, x-axis shows voltage cutoff, and y-axis shows LV extent. There was a positive linear relationship between voltage cutoff and LV extent. So when we increase voltage cutoff from 0.5 to 1.5, LVA extent linearly increased. These data suggest that the presence and extent of LVA reflects the global voltage reduction. So can the LVA be a target for AFib substrate ablation? Although we previously reported, as I showed today, the efficacy of LVA ablation. But based on this study, my current opinion would be no, because LVA is a reflection of global voltage reduction. So why LVA ablation improved outcomes in previous studies? So this figure shows the relationships between mean LA voltage and the inducibility of left atrial macro-reentrant tachycardia. There was three examples of left atrial macro-reentrant tachycardia. So the LA macro-reentrant tachycardia was induced in a total of 20 patients among the 140 patients. 40% of Q1, 9% and Q2 and Q3, and none of in Q4. Almost and multiple AT was induced in 9 patients, and all of those patients were categorized into Q1. And the critical isthmus of the AD were identified in the LVA, especially defined as less than 0.5 millivolt in all patients. So the second question is, why LVA ablation improved outcomes in the previous studies? So my answer is that LVA ablation might have eliminated a substrate for LA macro-reentrant tachycardia in the previous studies. So what is the primary cause of atrial voltage reduction? There was no histological validation reported. And so we, among the 140 patients, we performed atrial biopsies in 28 patients and histologically evaluated. So this is a biopsy site, and we got a samples specimen from the limbus of fossa ovalis here. And you can see steerable sheaths and the limbus of fossa ovalis in an ICE image. So here is the fossa ovalis. And we got a sample from here, the limbus of fossa ovalis, and you can see the biotome here. And we also use fluoroscopy, and this is our example of biopsy sample, about 2 to 3 millimeters. This figure shows an examples of biopsy, histology of the biopsy specimens. There was a various amount of fibrosis from 2% to 20%. The patient in figure A shows no low voltage in the left atrium and the right atrium. And the bipolar voltage at the biopsy site is about 12 millivolt. And the histology of this patient had no fibrosis, about a minimum fibrosis, about 1 to 2%. On the other hand, the patient in figure B shows extensive fibrosis in the left atrium. And the bipolar voltage at the biopsy site was 4.5 millivolt, much lower than that of patient in figure A. The histology shows extensive fibrosis, about 20%. So this figure shows the relationship between bipolar voltage at biopsy site and fibrosis, and the relationship between mean LA voltage and fibrosis. There was a negative linear relationship between bipolar voltage at biopsy site and fibrosis, and also between mean LA voltage and fibrosis. And this figure shows the relationship between bipolar voltage at biopsy site and mean LA voltage. There was a positive linear relationship. So in conclusion, LVA is a local reflection of diffuse voltage reduction, the primary cause of which was histologically revealed as fibrosis in this study. Low voltage area would not be an exclusive substrate for AFib, but could be a substrate for left atrial macro-reentrant tachycardia. Currently, we do not ablate LVA as AFib substrate modification, but we target LVA as AT substrate when AT is induced after PVI. Let's see a video live demonstration. And I hope the content of this study would be published soon in the near future in some journals. Hi, this is Takanori Yamaguchi from Saga University, Japan. Thank you for inviting me to this workshop. Today, I'll show you a live video demonstration of AFib ablation based on left atrial bipolar voltage. Today's case is an active 80-year-old man. He is a patient with persistent AFib with a history of congestive heart failure and coronary artery disease. His LA diameter is 43 millimeters, and he has no valvular disease. His LVEF is slightly decreased at 50%. The patient had a severe shortness of breath on exertion, and we decided to perform catheter ablation. Now, let's proceed to the live ablation video. The system used for today's ablation is EnSite Precision HD grid mapping catheter and TactCath ablation catheter. The procedure is performed under deep sedation. After external DC cardioversion, voltage map of the right atrium septum is created using the HD grid during right atrial appendage pacing. This is a part of our clinical study that I showed you today. We performed right atrial septum biopsy under the guidance of intracardiac echocardiography. A biotome, you can see right atrial septum and the limbus of the fossa ovalis and the biotome here. A biopsy sample has been just collected from the limbus of the fossa ovalis. You can see a biopsy specimen of about 2 millimeters. The pathological findings of this specimen will be shown later. We also use fluoroscopy to safely perform atrial biopsies. We have performed 150 biopsies so far with no complications. We also perform biopsies from right ventricle. Then high-density left atrial voltage map is created using the HD grid catheter during right atrial appendage pacing. We will eventually create a voltage map, but initially we create an activation map to avoid defects or premature atrial contractions, which can affect the voltage map. If there is a premature atrial contraction, we exclude that beat each time. Once the deactivation map is created, it is converted to a voltage map. The current voltage cutoff is 1.5 millivolt, but from now on, we use a cutoff of 0.5 millivolt. There is a low voltage area at the base of the LA appendage. First, we perform PVI from the right PV and then left PV at the setting of 30 watts, 10 to 20 grams of contact force, 200 grams of FTI with the dragging fashion. After PVI, CTI-dependent flutter was induced in this case, so we performed CTI ablation, and the block line was completed. Then we tried to induce atrial tachycardia by rapid atrial pacing, and a stable AT of 290 BPM was induced. Then activation map with the reentrant mode was created using HD grid during atrial tachycardia. This tachycardia circuit did not seem to be roof dependent or perimitral. At first, it seemed to be a localized reentry of the anterior wall. However, the activation map did not satisfy full cycle length of the AT. And the activation seemed to break out at the lateral wall. Therefore, we considered that this circuit partly includes the epicardial side. Under the hypothesis that this LVA works as a critical isthmus for the AT, we decided to target this LVA defined as less than 0.5 millivolt. After several RF applications, the AT slowed down and terminated. At the setting of 30 watt, 10 to 20 grams of contact force and 200 grams second FTI, we continued ablation to make a linear line along the LVA, surrounded by white lines. The same AT was induced again by rapid atrial pacing, so additional ablation at the LVA terminated again. And any AT was no longer induced. Thank you for watching this video live. We have successfully performed PVI, CTI ablation, and ablation of left atrial macroentrant AT in this case. The circuit of the atrial tachycardia in this case is difficult to visualize accurately, probably because it contains part of the circuit on the epicardial side. However, the tachycardia was reproducibly terminated by radiofrequency ablation in the low voltage area defined as less than 0.5 millivolt, which was identified by voltage mapping during right atrial appendage pacing. The circuit of this tachycardia was postulated to ascend the endocardial side of the lateral wall and the left PV ridge, and move to the epicardial Bachmann's bundle at the base of the left atrial appendage, where a low voltage area is seen during right atrial appendage pacing, and then break out to the left atrial lateral wall via the Marshall vein. In my presentation prior to the live video, I mentioned that the low voltage area is not the exclusive substrate for AFib. Rather, I explained that the low voltage area defined as less than 0.5 millivolt acts as a substrate for atrial tachycardia in the left atrium. This case was a good example of how the low voltage area works as a substrate for left atrial tachycardia. In conclusion of my presentation, I believe that voltage-based ablation can be an efficient ablation strategy for left atrial AT induced after PVI. In addition, pathological evaluation of the biopsy specimen later showed the highest degree of fibrosis among the biopsy cases we had experienced. There was no amyloid deposition. Thank you for watching this video. I hope we can meet and discuss with you in person next time. Bye.
My dear friends, thank you for giving me the opportunity to share my experience about cryoablation in persistent atrial fibrillation. These are my disclosures. As you all know, in the last guidelines, there is a class 1 indication for a complete electrical isolation of the pulmonary veins for all AFib ablation procedures. That means that you also have to disconnect the veins for the persistent atrial fibrillation. You are also aware that the cryoballoon is a very simple to use, straightforward, reproducible tool for performing PV isolation. In this setting that we are using in my lab, you can see a fusion between the CT image and the fluoro, in which the cryoballoon is inflated at the ostium of the right superior pulmonary vein, very stable, and the achieved catheter that is just at the top of the balloon is providing real-time information about the conduction between the left atrium and the pulmonary vein itself. Indeed, in this slide, you can see very easily that the PV potential, there is a prolongation, progressive prolongation between the left atrial far field and the PV potential, and suddenly between this bit and this bit, disappearing of the PV potential. That means that you have at this time a disconnection of the pulmonary vein. That means that you have an entrance block. So it's easy to assess. With a little bit of experience, a little bit of skills, and spending a few time, maybe 1 or 2 minutes, to assess the PV potentials, you can obtain this situation in more than 90% of the pulmonary vein. So you can obtain a real-time assessment of the PV isolation in more than 90% of the pulmonary veins. And at the same time, you can also obtain a single-shot isolation in between 80 to 90% of the pulmonary veins. And this is the reason why I used to say that the cryoballoon is, until today, the only single-shot tool for PV isolation. Maybe it will change in the future, but until today, in my opinion, it's the only single-shot tool for the PV isolation. But when you are doing PV isolation, you are doing more than PV isolation, because you all know that all around the pulmonary veins, you have many structures like fragmented potentials, reentrant circuits, you have also rotors, and while placing the big cryoballoon at the ostium at the antrum of the vein. You are, of course, isolating the pulmonary vein, but at the same time, you are providing substrate ablation all around the vein. And this is very easy to assess with a high-density voltage map. In this example of a relapse in a patient that had a first ablation procedure, you can see that after the cryoablation with a 28 millimeter balloon, when you are doing the high-density voltage map of this posterior wall, you can clearly see here that nearly the 2/3 of the posterior wall has been treated by the balloon. It's in red, so low voltage. So in this case, you are also, of course, disconnecting the PVs, the 4 PVs, but not only, you are also providing substrate ablation of the 2/3 of the posterior wall. This is the reason why, since many years, we believe that the PV isolation with the cryoballoon could be a good first option for the persistent AFib, namely for the short persistent AFib. And this is the reason why we did this trial a few years ago with many European centers, in which we included a little bit more than 100 patients, in which we provided a PV isolation of the four pulmonary veins. PV isolation only. It's a less than 1 hour procedure, so it's short. For persistent AFib, it's a very short procedure. And the success rate is about 60% at 1 year. The success rate was defined as the absence of relapse of a more than 30 seconds atrial arrhythmia. So quite strict definition of recurrence or success rate. It's not so bad, but of course it's not a miracle, because you still have 40% of patients that have recurrences. So that means that we need something else. We also know that since many years, and namely in this trial from Atul Verma in STAR-F2, providing fragmented potentials on top on PV isolation, lines on top of PV isolation is not also the solution, because here also you get globally more or less about 60% of success rate. So it's not doing better than the cryoballoon itself with a less than 1 hour procedure. And this is certainly the reason why in the last guidelines, the use of additional lesions beyond the PV isolation is a class 2B indication alone. It doesn't mean that you don't have to do it, but it means that if you do it, maybe you don't do it for all the patients and you have good reason to do it. So what can we propose with the cryoballoon? We can propose something else than the PV isolation alone. For example, we can perform quite easily a nice roof line with a cryoballoon. You can see here that the balloon is placed, and it's placed sequentially all along the roof of the left atrium in order to provide a complete line of the roof. In this very nice paper from Bad Nauheim, you can see that 200 patients more or less were divided in 2 groups, RF group and cryoballoon group. So PV isolation by both energies for all patients. But in 40% of patients of the 2 groups, more or less 44 in RF and 43 in cryo, a roof line was added with both energies, RF in the RF group and cryo in the cryo group. And the success rate is interesting because in both groups, it's not significantly different, despite the fact that cryo seems to be a little bit better, about 70% at 2 years, versus around 60% for the RF, but it's not significant. You can see the p-value here, 0.2. But if we consider the subgroup of an additional roof line, with the roof line, the cryo is doing much better. You can see that this time it's really significant, with a p-value that is less than 0.01. And it makes sense, because with a radiofrequency, you can perform a roof line, but this roof line is thin. With a cryo balloon, you have a 28 millimeter diameter tool that provides a very wide roof line. It's like an highway when you are performing a high density voltage map after roof line with a cryo balloon. So it seems quite clear that you may have less risk of recurrences on the roof, less gaps, and this is the reason why I believe that the cryo balloon is very efficient for that. But you can also do left appendage disconnection with a cryo balloon. It's also something that is feasible. And the first paper that described this was the one from Yorgun from Ankara that included 200 patients separated in two groups, not randomized, but separated in two groups, PV isolation alone, so here consecutive patient with PV isolation alone, and patient with PV isolation plus left appendage isolation. Follow-up of 1 year, and you can see that the follow-up is clearly in favor of PV isolation plus left appendage isolation, with a success rate at 1 year for this group of nearly 90% at 1 year versus the always around 60% of success rate for the PV isolation alone, like for the cryo persistent. Finally, you can also perform a posterior wall isolation with a cryo balloon. And this is the experience, very nice experience from Arash Ariana from Sacramento, in which they perform a complete box of the posterior wall, what we used to say the box, with a PV isolation, of course, roof line, and a posterior line. You can see that the procedure is quite impressive. It's difficult, a lot of cryo applications. It needs a lot of skills to maneuver the sheath and the cryo balloon all around the posterior wall in order to disconnect the posterior wall. But it seems very interesting. You will see the success rate. It's interesting, but it's difficult because in 30% of the patients, you need to use additional RF applications in order to close the gap. It's quite easy, we were saying before, to isolate the veins. It's quite easy to perform the roof line, but it's very difficult to close completely the posterior line. And namely, the point in the middle here with the balloon is very often very difficult to perform here. And sometimes you need to add RF applications in order to close completely the posterior wall. But the success rate seems to be very promising, with a sinus rhythm at 1 year of around 90% again. And again, the same 60% more or less for the PV isolation alone. So the posterior wall isolation seems also very promising. In conclusion, my friends, I would like to say that cryoballoon ablation is a reasonable, effective, and safe option for the first ablation procedure. It provides a high rate of durable PV isolation with very wide antral lesions. I think that this is very important. It's very important to say also that it's a fast procedure with low fluoro times, usually when it's PV isolation alone between 5 and 7 minutes if you have a little bit experience. You can provide additional left atrial substrate modification besides the PV isolation, and extra PV ablation are feasible and this is under investigation. So the roof line, the left appendage, and the posterior wall isolation, and maybe more. So if you agree, I would like to share now with you a small video that we performed a few weeks ago in my center in order to show you what is our strategy at the present time for short persistent atrial fibrillation in order to provide not only PV isolation, but as you will see, we're beginning with this. We are first isolating the pulmonary veins and then provided some more substrate ablation. So this video shows first the way that we are making the fusion, as I was explaining before, between the CT scan image and the fluoro. You can see here the transeptal that we are performing with the fusion image. Here, the sheath is on the left side. We are placing the sheath on the left side. The guide wire is in the left superior pulmonary vein. Then we will place the flex cut, which is the 15 French sheath inside the left atrium. Now the flex cut is inside the left superior pulmonary vein. And then we will start with the left superior PV isolation. You can see that here we are inflating the balloon at the ostium of the vein. You can see here a complete isolation of, a complete occlusion, sorry, of the left superior pulmonary vein. You can see here the real-time assessment of the PV potentials and progressively increasing of the cycle length during freezing. The freezing is starting here. You can see the freezing -17, -20, and you can see here the prolongation of the cycle length of the PV potentials, and here, finally, a real-time assessment of the disconnection at this time of the left superior pulmonary vein. It's usually a single shot application of 4 minutes, and usually you obtain the disconnection within the first 60 seconds. But of course, you add 2 or 3 minutes more, 3 minutes more, namely in my lab, in order to obtain a high durability of the PV isolation. Now we will move to the left inferior pulmonary vein. You can see that we will move the sheath here. We will bend the sheath. We will go more posterior in order to place the achieve catheter in the left inferior, then the balloon, inflating the balloon at the ostium, and the hockey stick positioning. You can see that you have a complete occlusion here of the left inferior. And again, we will provide here the freezing at the antrum of the vein. You can see here very tiny PV potential, but you can see it very clearly. And you can see also the prolongation of this PV potential. And again, here, you can assess the real-time disconnection of the left inferior pulmonary vein. You can see it's 20 seconds, so it's a very fast, again, less than 1 minute, single shot application for left inferior PV isolation. Then we will move to the right inferior, but before phrenic pacing, in order to assess the phrenic nerve action and to prevent from phrenic problems in the right veins. So we are placing the pacing catheter very stable at the ostium of the subclavian vein. And now we are moving to the right inferior pulmonary vein. You can see here that we will inflate the balloon. The balloon is now inflated at the ostium. You can see that we are very antral. Again, this is AP view. And you can see here again the PV potentials. Not very fast, but they are okay. You can see now we are freezing. We start freezing now. So it's you can see at the real time what happens, decreasing of the temperature, now -1, -7. and you can see the prolongation of the PV potential. This is real time, between the freezing and the PV potentials here. And again here, one shot disconnection of the right inferior. We are pacing now for the phrenic in order to assess the phrenic nerve function. We are pacing at minus 20 degrees because before it's not needed to pace. And now we will move to the right superior pulmonary vein. We place the achieve catheter like a guide wire at in this vein, the right superior. We are placing now the balloon progressively at the antrum of the vein. We are inflating. We are fixing the balloon with a sheath, and now with the achieve catheter, we are coming back to the balloon in order to assess the PV potentials. They are little, but again, we can see them very well. And again, real-time cryo, you can see we are starting because it's green, decreasing. The temperature is now 0 degrees, -5, and you can see at the real time the separation of the PV potentials of the right superior, and again, a disconnection within 20 seconds. So again, it's fast, and again, the phrenic nerve pacing in order to assess the phrenic nerve functioning. So that's done for the veins, but we will not stop there. We will go now to the roof. So you can see the phrenic nerve pacing, and we will start the roof line, placing the achieve catheter, anchoring the balloon in the right superior pulmonary vein. So we are using the achieve catheter like an anchor, and we are moving counterclockwise the balloon all along the roof with a first application, second application now. So sequentially, we are moving all across the roof, and you can see that we are using the fusion image because the fusion image is giving us the positioning of the balloon. Third application and the fourth application right now. Okay, so the roof line has been performed with 4 applications of 3 minutes each all across the roof. And now we'll check with the achieve catheter the roof. You can see here no potentials. We are moving the achieve catheter all along the roof. You can see nothing. So it's completely the desert on the roof, like a highway I was explaining you. And we will finish with the appendage isolation. You can see that we are placing the achieve catheter in the appendage. We are inflating very cautiously the balloon at the ostium of the appendage, very cautiously, because the appendage is fragile, as you all know. We are not pushing too much here. And once the balloon is inflated, now we can push with the sheath in order to occlude the appendage. You can see here that the appendage has been occluded. Now we can start freezing. To disconnect the appendage is much longer than the pulmonary vein because it's a thick tissue. You have the ridge here, and I personally believe that the ridge is very important. And this is one of the reasons the appendage may be interesting for persistent AFib ablation. You can see here the potentials of the appendage that are prolonging. Cycle length is becoming longer and longer, and the temperature is decreasing. You can see here more than 2 minutes, so it's much more difficult than the PV again, but you can see that you have here a separation, a disconnection of the left appendage. And you can see here on the right panel, the review screen, that you have a progressive disconnection of the left appendage. Within more or less, a little bit less than 3 minutes, 150 seconds, 130 seconds. Usually it's more than 2 minutes. And we'll finish by a cardioversion of the patient. Sometimes we have the chance that the patient is becoming in sinus rhythm during this procedure, but not always. I would say around 10–15% of patients are returning to sinus rhythm, but it's not usual. Usually we perform a cardioversion of the patient at the end when we did all this setting. And you can see here within a few seconds the cardioversion and the returning to sinus rhythm. Within the next seconds. So you can see that it's a quite straightforward procedure with only a single balloon. We don't use anything else. You can see here the cardioversion, sinus rhythm, stable sinus rhythm, and the ablation is finished in more or less 80 to 90 minutes, so 1 hour and a half, more or less. And this is nowadays our policy for persistent, short persistent atrial fibrillation as a first approach. Thank you very much, my dear friends. I hope that this presentation and this video was interesting for you. Thank you again.
Hello to everyone. My name is Ante, coming from University Hospital Center in Split, Croatia. And here I'm with you today to discuss on a first-line cryoablation trials for paroxysmal AF. I'm talking about recently published 3 trials on a cryoballoon ablation for paroxysmal AF. And we're going to discuss this topic in the broader aspects. These are my conflicts of interest. As for introduction, let's ask ourselves why ablation is the first line? Why the rush? Well, I think we all know that less AF means less left atrial remodeling, less fibrosis. We don't like fibrosis. And why pulmonary isolation is the only treatment option? I think that all of us know that long-term antiarrhythmic drug therapy is a road to nowhere, especially in paroxysmal AF population. And the earlier we intervene, the greater the chance the patient will be PVI responder. What did change till, let's say, last Prague meeting? I would say that we get another 2 trials that testify for the strategies we've been, incorporating in our labs for years. And it goes for simple bottom line. Sinus rhythm matters on the longer run. We all understand that. So I would like, for a kind of introduction, I would like just a quick, take a quick touch on the East AF and 4 trial, because I think it's finally solved the puzzle, rhythm of rate control, and see here that if you imply early rhythm control over usual care, it comes to the statistically different, outcomes. And so the early rhythm control, I'm not saying ablation, I'm just saying that, this time patient do not accept AF. We're going to fight AF, and we are not talking about, some weak endpoints. We are talking about crude cardiovascular endpoints. So cardiovascular death, stroke, hospitalization with worsening heart failure or acute coronary syndrome. So this means a lot. I think it's a proof of concept that the sinus rhythm matters. Another good trial, another good signal we have as an ablationist is that the question is, AF ablation delays progression to persistent AF? Well, it seems from a test AF trial that the progression, the yearly progression, the annual progression to the persistent AF in a paroxysmal patient that are underwent ablation is close to 0. Unbelievable, but we do see this in our practice, and especially with the newer technologies, I think this will stood the test of time, and this is a great news. So how does the cryoballoon fit into this AF story? Well, cryoballoon is a good PVI tool. All PVs durably isolated in 60 to 70% of patients when treated with the latest generations of cryoballoons, which is a fair result, and it translates in a reasonable effectiveness when talking down and coming down to the aspect of proportion of patients being free of AF, and it comes with a reasonable safety. This is very important because we talk about paroxysmal AF patients. They don't have such a nasty disease. It's just paroxysmal patients. It's annoying, but it's not nasty. It's not cutting the longevity. So it has to be super safe. On an institutional level and a healthcare system level, it is important that cryoballoon ablation is reproducible. It has reproducible procedural time, and it's easy to master. We know that, compared to point-by-point ablation, fellows are becoming, masters of cryoballoon after 20 to 25 cases. Well, taking all this together, I think that now when we know this, and now when we take a short look at the RF data, at the old RF data, we now understand why this new cryoballoon randomized controlled trials were primed to be positive trials. Take a look at the old data. So I'm trying to remember all those studies, and those 3 studies. The first line, RF ablation, RF attempts, to control AF with the old generation point-by-point radio frequency catheter ablation, and even this trial, even this technology that would rarely result in all 4 ways being isolated, had shown the promising, signal. So you now understand that the cryoablation, was primed to be a successful story when put in this context of paroxysmal AF. So I'm talking about two trials published online in late 2020, and we have now published in peer-reviewed journals in 2021. So early AF, randomizing 303 patients to pulmonary vein isolation with cryoballoon or enteric drug. Stop AF, CRYO-FIRST, all the same trials. Paroxysmal AF patients, 2 arms, PVI versus enteric drugs, and the endpoints, primary efficacy endpoint was always freedom from any atrial arrhythmia recurrence. The follow-up method did differ, from intermittent to the continuous with the loop recorder, and you will see how does it translate in outcomes. And these are primary efficacy endpoints for these 2 trials. Of course, as you would expect, with a more stringent monitoring method, such as implantable loop recorder, the absolute numbers are going a bit down, but still it's a fantastic, success. Let's take a look here. Around 60% of patients are free of short AF episodes. I think these endpoints are more meaningful because they are symptomatic paroxysmal AF patients. So it does make sense to have this endpoint, watching, paroxysmal and symptomatic AF episodes, occurring. And no matter what was the follow-up method, the consistent relative risk reduction was observed. And it was pretty much, hazard ratio 0.48, hazard ratio 0.48, so it's a very reliable, very reproducible. And this is what we needed years ago, talking about PVI tool. Another important aspect here, especially studied in early AF, since patients are followed with the implanted loop recorder, is AF burden. I think this is super important metric for the long-term outcomes. And you see that in the patients undergoing ablation, the time spent in AF was 0.1% of the follow-up period. This is fantastic news, and this is something that has to translate in a crude and good cardiovascular outcomes. Secondary efficacy outcomes, like an early AF, are followed, no matter what the question of the quality of life, all were improved in ablation group. So ablation, at the end of the road, ablation, improves quality of life by suppressing AF. Primary safety outcomes, let me cut it for each study. I think this is a super important aspect, the safety. So CRYO-FIRST, very freshly published in Europace. Look at this, time to first serious adverse event, it did not differ, and there's no statistically significant difference in patients undergoing ablation or antiarrhythmic treatment. So in a PVI group, in an ablated group, 107 patients, no stroke, no tamponades, no persistent pharyngeal palsy, a single TIA case. Early AF, definitely ablation met performance goal, very low overall complication rate for the procedure-related complication rate. Again, 154 patients in ablation group, no stroke, no tamponade, 3 persistent phrenic palsy that persisted toward the end of the procedure, but definitely resolved at 1 month follow-up, and no TIA. And finally, overall serious adverse event, you see there's no difference in a magnitude of serious adverse events. Finally, the early AF, PVI group consisted of 104 patients, no stroke, no death, no persistent phrenic nerve palsy until 12 months follow-up, and no AE fistula. Of course, you can. I think it's not worth mentioning AE fistula in a context of such a low number of patients, but it's definitely reassuring that there's a third study showing there's no stroke. And overall adverse event rate was similar between 2 groups: ablation, drug therapy. It doesn't matter. Similar adverse event. So, what are the take-home messages? I think that safety aspect-wise, these 3 recent randomized controlled trials, STOP AF FIRST, CRYO-FIRST, early show that PVI with cryoballoon as an early treatment option for paroxysmal AF patients is as safe as a drug. This is very important. But with the caveat that these procedures were performed in high-volume centers with high-volume operators. And these were industry picked. And this might look very rough, but actually I like this. I very like this because industry picked the high-volume operators and they delivered extremely safe procedures. This is what we needed. And this sets the performance level. I congratulate the operators. I congratulate, PIs, because, in this trial, we get what we know, the performance level. Now we talk about later on medication, but this is as good as it gets. About AF suppression aspect, these 3 trials show that PVI with cryoballoon as an early treatment option for paroxysmal AF patients results in better control of AF. And this is irrespective of follow-up strategy. So treatment effect is preserved, no matter the follow-up strategy. This is very important. Again, when performed at high-volume centers with high-volume operators. This is very important to understand. These trials should impact the guidelines because that in the latest version of the guidelines, and now when we add these new studies and put it in context of East AFNet and test study, I think that this level of evidence and should be changed, and we have definitely more randomized controlled trials now to say it's a level of NSB. Should it be class 1 recommendation? Well, it's a matter of debate. I think 1A, it's well deserved for the ablation arm now. My personal take on these 3 randomized controlled trials with cryoballoon for persistent AF would be: the question 1 I have: will this data change my practice? No, I already knew that the ablation helps people. Ablation helps AF patients. It stops progression to persistent patient, improves quality of life. Did these trials bring in any new data? Actually, no. I knew that cryoballoon can be safe if you really exercise all those precautions, take care about esophagus, take care of sphenic nerve, and it's absolutely beautiful to see that in 480 patients included in these 2 trials, we didn't have a single instance of a stroke. It's very important. Do these trials suggest the cryoballoon supremacy or the widely available ablation platforms and approaches? I'm going to be provocative, yes. I think that cryoballoon is extremely safe, reasonably effective, and it is the tool that has been, better than what we had traditionally. And is there a reason for the cryoballoon program managers to laugh? I know that there have been improvements. You all know that now we have another cryoballoon platform with some of the aspects being improved over this platform that being tested in these 3 trials. But I think that with the advent of this PFA, pulse field ablation single shot PVI, the cryoballoon will be challenged. And it's my personal perspective, in 2023, probably the cryoballoon ablations will be pushed away from the market and superseded by some kind of single-shot PFA platform. With this in mind, and probably you must have your own opinion after seeing the live case yesterday, I thank you for your attention. Bye-bye.
Hello, everybody. I would like to thank you for your nice presentations. It's nice to see you at least on the screen. I hope that we will meet in person in next year or somewhere, if not in Prague again. And we can start discussion. We can start debate. We have a couple of questions from the audience, but maybe we can start with a sequence of lectures. So let's start with Tim. Do we have question for Tim?
I would have one. That was very interesting. My question is, how many regions you usually have to target before you have either organization or termination of atrial fibrillation? To be honest, we tried the Cardio Insight system to map the AF, and we generally ended up to target about 4 regions out of 7 biatrial, and that meant that we have to ablate nearly half of the biatrial surface to really achieve something, which a little bit loses the beauty of mapping of atrial fibrillation. So how targeted is the ablation with the Acutus system? And
that's a very, very good question, because although you might have the perfect mapping system, but you still have to be able to interpret it and understand it and know where to target. So one of the secrets, as I mentioned earlier in the talk, is that to do repeated maps and look for something which is very consistent. Now, sometimes that might be very near a pulmonary vein and is included in the encirclement, and then we remap. I mean, for me, on average, it's probably somewhere between 2 and 3 areas get targeted per case. But it varies from 0 to I've done the left atrium, the right atrium, and still cardioverted. I'm beginning to also learn and understand when I've done enough in the left atrium and it's time to move on to somewhere else. When you have true chaos and nothing consistent, and there's an impression it's being driven by the right, you can move over. It's very variable, but then you'd expect that because we have a very extreme range of patients who come to the lab. And as you've heard so elegantly from the other speakers, we can get a good result in 50, 60% of patients just with PVI. So there are some people who won't need targeting outside of the veins. So it's a very individualized approach.
Well, Tim, I have, and maybe when we discussed together, I already mentioned, I have always some methodological problem how to accommodate this experience from this strategy or from Cardio Insight with experimental data showing that there might be some rotors, but they are small, very small. But here you have rotor which goes around the whole atrium or even both atria, like with Cardio Insight. So how you can explain this?
Yes, no, that's a very good point, because we've all seen, for example, when we've done PV isolation, sometimes the vein continues to fibrillate and the rest of the atrium's in sinus rhythm. So we know AFib can take place in a very small surface area. I mean, I think sometimes if there is a micro reentrant driver, it will just look like a focal macroscopic phenomenon. So you can still localize yourself into that area. But yes, it's the translation of something from microscopic to macroscopic which one has to look at. And I think we're still learning that process. But I still believe that global mapping is the way to sort that out. And it seems to add an edge, but we still don't have a 100% success rate.
Do you think that with technologies like yesterday, we could see, for instance, two cases of Affera pre-recorded, where you can do box lesion, you can do mitral isthmus line, and these lesions seems to be very durable because we remap patients after 3 months. So if you really particulate the right atrium and left atrium, like MACE procedure, do we still need in the future mapping?
Well, I think that that's true if you have fantastic durable lesions first time round and you do every possible lesion set, you'll probably get a very good rhythm result. But how much of the atrium is left to contract, whether you get stiff atrial syndrome? I mean, I still think less is more. We should be burning or ablating as little as we can to get the best result, not napalming everything.
Maybe final comment, price. I calculated when I visited different places where this technology has been used, and I calculated how much it would cost us, and I felt that we cannot sustain this cost. I mean, in long term, if we use it for all persistent cases, so.
It's very individual, I think, for each country. So I think when you came to see cases in our lab, we were using it combined with precision so that we could have contact force. Well, we don't need to do that now because we can use it with the AccuBlate system, which is the biotronic gold tip catheters. So we get contact force there. Also, I think I demonstrated it has the contact module if you need to use it. So you can use it standalone. And then it's down to the cost of the AccuMap array versus the cost of other equipment like the cryoballoon. And in the UK, the cryoballoon is very expensive. So, and if you do away with an ice probe, if you don't need that, and you reduce the number of redo procedures, it could become cost effective.
Okay, so let's move to second talk.
Yeah, that was the Jose. I would have a question for him. As he mentioned in his talk, which was very nice, he mentioned this long-term outcome and efficacy of the high-power short-duration lesions from the meta-analysis that was published in Europe. So he mentioned also that he might comment on that. So why you think that because it's much shorter to do the high-power short-duration, but maybe there is this problem with the long-term efficacy. So any insights? Why is that? Because acutely it looks perfect.
Yeah, it's a very good question. In fact, it's a kind of conflict because we are trying to achieve first a rapid procedure, so to compete with cryo. Second is to have a safer procedure. That means less deep lesions in order to prevent collateral damage. But if you have less deep lesions, means that you may have some residual conduction left. So this could be part of the explanation. The other part of the explanation is that for any new technology, you need a learning curve. So maybe the way how we overlap lesion is not sufficient. So the only way to really know the answer to this question is to conduct a randomized trial. That is what we are doing now. We are randomizing patients to conventional approach, conventional settings, and to high-power short duration. We are conducting a multi-center trial on this, and we are in the middle of the trial right now.
Okay. And based on your experience, does it make sense to apply more, for example, on carina, on anterior part, rather than the posterior wall? Because posterior wall is very thin, and usually 7 seconds of 70 watts may not be, or 90 seconds may not be necessary. On the other hand, for deep lesions, you need conductive heating maybe more. So because I don't really like this concept that you apply just the same everywhere, because you're losing a little bit potential of titrating the power. So maybe if you can comment on that.
Yeah, I fully agree. For the trial itself, we are, in order to have it simple, we are not titrating the power for PVI. So we are delivering the same power for PVI. However, when we are dealing with persistent AFib, we are doing other things. And in general, in the posterior wall, we are delivering high power because we think that is safer. But in the anterior wall, we think that this is thicker. And then we use conventional settings, 40 watts, because we think that conventional makes deeper lesions than high power.
There is one question for you again. Do you look for LSI or ablation index during high power PVI, or just look for time?
Yeah, no. It's just time, 9 seconds in each side, but we pay attention to the LSI, an ablation index. The point is that these indices have been not developed
or validated with this amount of power. So they can be used just as an indicator, but not really as you can't rely completely on that. But at least I think that they can give you an idea. And in fact, before ending with this 70 watts and 9 seconds, we tested different powers. For example, the first article that we published was 60 watts. And we had the impression that after having the first pass, the amount or the percentage of veins that were isolated were not as high, together with the LA size that was not really exciting. It was in the range of 5 or so. So this is why this motivated us to increase a little bit more the power to 70 watts. And now we are getting 6, more or less, depending of contact, of course.
Well, if I look into our experience with diamond tip technology, we could see it's faster also, and you can apply up to 50 watts. But sometimes you have a drop in impedance, which is very high within 6 seconds, and you see even whitening of the tissue on intracardiac echo, which means that you are close to 100 degrees in the tissue. So for me, and it varies in different areas, you have different whitening or different speed of lesion formation. So I'm a little bit concerned that you have only time like 7 seconds and then you apply everywhere the same. So I would still feel that some kind of technology which allows you to sample quickly and show this impedance drop and like diamond or Q dot will be preferential for this high energy short duration compared to conventional irrigated tip catheter. But maybe I'm too overcautious.
No, I think that you are right. We have had very few high prices of impedance, and they are mostly found or happen when you have, for example, high contact force over 20 grams, and also if you apply in a place that has been ablated recently, because probably you have already edema there, and then let's say the covering of the tip of the catheter by the tissue is different. So maybe with the same amount of force, you will have more interaction of the catheter tip with the tissue, so more energy delivered to the tissue, and then more chances to have impedance rises.
Is there any data comparing this strategy with conventional, let's say, RF strategy in terms of silent lesions in the brain? voltage mapping compared to point-by-point or some other multipolar catheters? Because it varies based on direction of the activation wavefront.
Yeah. Yes, HD grid decrease the directional sensitivity. So the voltage using HD grid is more accurate than other multiple mapping catheter. And so if you want to create accurate voltage map, we need to consider directional sensitivity. And so HD grid is very important. But when we compare the voltage between ring catheter and HD grid, when we select highest voltage at very smaller part, I mean, I calculate the LA voltage using highest voltage in each 1 squared centimeters, and then compare the voltage, left atrial mean voltage between ring catheter and HD grid. The relationship is totally linear. So directional sensitivity is the most important factor that affects pseudo-low voltage.
There is a question for you from the audience. Do you recommend looking at voltage mapping in sinus rhythm or AF rhythm? I think it's obvious that it should be in sinus, but I wonder what you answer.
Yeah, in my study, I created a voltage map during right atrial appendage pacing, and it almost same with during sinus rhythm. And the voltage during right atrial appendage pacing is linearly related to fibrosis, histological fibrosis. But today I didn't show the data, but the voltage during AFib does not correlate with fibrosis. So I totally recommend create voltage map during sinus rhythm or some kind of stable pacing rhythm.
Yeah, that's very true. I was surprised when we tried to map one patient in the atrial tachycardia during sinus rhythm and during atrial fibrillation. It looks like completely different patients. You know? So we have the same experience in different studies, but yeah, this is very important to select the proper rhythm.
May I have one question? It was very nice. I really enjoyed, but you showed during the case that you, after PVI, induced regular atrial tachycardia, and you said that these low voltage zones are important for this regular macroentrant atrial tachycardia. Yeah. So my question to you is, what do you do if you induce AFib after your PVI, and whether it does change your strategy? What is your strategy for AF?
Yeah, and in the previous studies, we ablated low voltage area empirically, and but I now noticed that low voltage area is not an exclusive substrate for AFib. So I don't ablate LVA if we don't induce, if AT is not induced. If only AFib is induced, I don't do anything. No more substrate modification.
I assume that from your early experience, when you did ablation of all these low voltage areas, this was not mapped with HD grid. So these areas were probably even bigger than today when you map with the HD grid. Is that correct?
Yes. Yeah, correct.
Okay. So, or if anybody from the panel has a question to anybody else, you can obviously ask. I mean, it's a friendly debate. So there are some questions from the audience, but you can ask any question.
I will continue with Dr. Boveda. Was a very nice case. I really it's very nice to do it with just one balloon, all this stuff in the left atrium. Obviously, there are two questions I have, and one is whether it's more dangerous to cryo the posterior wall with the balloon, whether this is in terms of esophageal damage. This is one question. And the second question, for your left atrial appendage isolation, that is an issue that always raises a lot of questions. There's one question from the audience. And my questions are two, whether you're seeing any thromboembolic events afterwards, because that's we saw when we isolate the appendage. The question is then, because it's more difficult with cryo to isolate the appendage, is that whether you think it's durable, if you have any data about durability of the cryo isolation of the appendage.
Yes. Very, very good and very important questions. I agree. So I will try to start with the first one about safety. As you have noticed in our cases that we do with the balloon for the roof, we always use the probe into the esophagus in order to assess the temperature. And when we reach 16 degrees, we stop the cryo application at 16, because there is some data from German centers that show that they can assess lesions in the esophagus with a fibroscopy after below 16 degrees, below 12 degrees, in fact. So we have a kind of a margin between 16 and 12 degrees. So we stop at 16 because you will see that when you are stopping cryo, the temperature is still decreasing a little bit during a few seconds. You have it's a remnant. It's not an on-off, you know. It's not because you are stopping cryo that it will stop freezing. In fact, the temperature is still decreasing a few seconds, usually about 10 to 20 seconds after stopping. So we decide to stop at 16 degrees. But it's surprising that very often we can see that the lowest temperature is not reached at the roof. It's reached very often in the right inferior vein, because the esophagus is not linear. It's going in a diagonal. And sometimes we are surprised to see that the lowest temperature is not at the roof. It's at one of the veins, and very often in the right inferior. This was the point about the esophagus, and I completely agree with you that it's a very important point. And this is why I recommend to use the probe into the esophagus when you are doing this kind of procedure. The second point about the appendage, it's also obviously very important. We have now an experience of more than 100 patients that we did appendage isolation, and we never had any thrombus, and we never had any problem of stroke, obviously, or things like that. And this is an important point, and I believe that it's related with the second part of your question. Is it a definitive isolation? I would say that for the roof it is, but for the appendage it is not. And in very often when we have a redo patient, we do, of course, obviously a second procedure with radiofrequency. This time we don't follow a second cryo procedure, so we do voltage map, high density voltage map, and we can assess that the roof is still isolated, but very often the appendage is not. The appendage seems to be reconnected in most of the cases. It's a slow reconnection. I would say that it's not a one-to-one reconnection with the left atrium, but there is still a mechanism into the appendage that you have a kind of decremental reconnection of the appendage. And this is the reason why I think that the appendage after cryo is not completely isolated for a long time. There is a reconnection, and this is certainly the reason why it's quite safe, because you still have a systole of the appendage. The appendage is not completely disconnected, and this is a second part, and I will stop after a few seconds, but I think it's important. I think that to ablate the appendage is important not for the appendage itself, but for the ridge. And I think that if you are performing the setting of the PV isolation, the roof, and the appendage, you are also ablating the ridge. And the ridge is, I believe, the most important, not the appendage.
I have, Serge, I have the same opinion that this is not about appendage, but it's rather about the ridge where you have Marshall vein innervation. Yeah. So data from alcohol ablation, for instance, show that you can kill this innervation and you may not need to do appendage. And we have impression that when we get real appendage isolation, when you have, for instance, mitral line, and then you do anterior line, and then you have full isolation, which is permanent, then this is the highest risk for thrombus formation. So my question is, did you try intracardiac echo to manipulate the balloon and see where you are ablating? Because this would be a very nice tool to place the balloon in different areas, and you don't need CT scan. And you also mentioned what we know for many, many years, that esophagus is not in the middle, or it's not on one side, it's usually diagonal. So in many cases it touches actually a right inferior vein. So there is no wonder that you have highest or lowest temperature close to this vein, or sometimes it's over a left inferior vein. So there is a different course in different patients. So again, if you see it on ice, you can somehow adjust your strategy for ablation, or you can be more careful when you are on the esophagus.
I agree, Joseph. This is a very good idea. Unfortunately, I don't have the experience of the ice in France. Ice is very few used in French centers, because I think the most important question is a question of cost, and we cannot reuse the probes of ice in France. It's completely something that we cannot do, and I don't have the experience, but I agree with you that it could be an interesting, very interesting approach in order to place the balloon. As you have noticed, I use the fusion with a CT scan to place the balloon in relationship with the anatomy of the left atrium. It's my kind of ice. It's not ice, but it's a different approach. But I agree with you that it could be very interesting to use the ice.
Could I ask a question about the risk of left phrenic nerve palsy when ablating the appendage, because you can capture it from the distal appendage, if maybe not the proximal? Have you ever seen this? And where would you stimulate to try and make the diaphragm hiccup?
Yeah, it's a very good point. To be honest with you, I never had this kind of situation, and it's true that we are not assessing the left phrenic functioning during appendage disconnection. I think that it's very difficult, in my opinion, because the balloon is placed very proximal. It's not distal, you know, and I believe, but maybe I'm wrong, we should demonstrate that, but I believe that the risk of left phrenic should be low. But I will remind your point, and for the next time, it's very easy to perform left phrenic pacing. You just place the catheter on the left subclavian, and you pace there, and you can very easily capture the left phrenic. It's not something difficult. I did for other cases, but for other reasons. But I agree that it's an important point. The point for the left appendage that has been very often reported is the risk of the circumflex. Again, I think that the balloon has the great advantage to be very big, very proximal. And I think that this risk is low. We never had this kind of problem. But again, we have to be very cautious. And again, it's not something that I would recommend to do for all patients on a routine basis. I think that we are selecting the patients in some very selective cases, and it's not zero risk. I agree with you.
There's a question also whether you try to assess velocity of the appendage or emptying function of the appendage several months after the procedure of isolation with cryo.
Yes, I agree. We did that, and this is the reason why I can also say that usually it's not a complete and permanent disconnection, because in most of the cases we have a velocity in the left appendage a few months after the ablation procedure. Mostly we are doing that for the redo cases. Again, it's not, as you have noticed, and I said that it's not 100% of success rate, obviously, and unfortunately. But when we have redo cases, we perform a TOE, and we can assess at this time the velocity in the left appendage, and it's never zero. It's never completely disconnected again. I believe that this is also an important point in matter of safety.
Okay.
Hello, Serge, is Ante. Can I intervene?
Ante,
I think it's very important not to miss this data, and not to try going over with the studies on a beyond PVI ablation without giving us a good data. What is the durability of those lesion sites? So imagine if you have in your center, if this is the approach to all comers with the persistent AF, I'm talking about PVI plus posterior wall ablation with a cryo balloon and then appendage isolation. I think that it's very easy to schedule a patient for 3 months to come back late. So 3 months after, you perform a TEE to assess appendage function, and the good echocardiographer should be able to give you this data. Is this structure active or not? And the second thing is just when you do TEE, you just put something down like any simple ablation, any simple diagnostic EP catheter to assess the left posterior wall isolation or silence. Because if you don't have electrograms down the esophagus, then the posterior wall is obviously still electrically silent. This is very important. We shouldn't be having any more studies on beyond PVI strategies without validation of durability of the lesions, because we are losing our time.
I agree. You're completely right.
Okay, we have some questions for Ante. There is one which says that it's not true that investigators were industry picked in all these trials, because in early AF, this was investigator-initiated trial, so it was not influenced by industry.
Just go, yeah, please just go on the back on the paper, on addendum or the paper, and you will find that that was supported by educational grant and Medtronic or whatever. So mostly this eventually, as a reader and as a professional, I read it as a industry-sponsored, industry-picked, centers. And as I said, I see it as a good thing, because, it sets the performance level. It gives you an idea, how this platform can perform in real life with high volume centers, high volume operators. This is very important.
What is important when we talk about cryo, I think there's a lot of data showing that the difference between experienced and less experienced or limited experience operators is much less than for radio frequency ablation when you use cryo. So this is again gives you more, let's say, feeling of safety that this technology can be used by even less experienced people with similar result like in experienced centers.
I agree. We faced too much of the platforms and the studies that cite super fantastic data, and then nobody could be able to produce that. For the first time in AF ablation history, in 2016, 15, or 16, with the advent of the second generation cryo balloon and the high volume operators, high volume centers, the multiple European centers, and then of course the US centers, have been able to reproduce this data. And this is the power of the cryo balloon: reliable, reasonably safe, and reasonably effective. And the most important thing is for the health, on the health level, health care and health system level, it can provide a tool with which you can cover substantial population of AF patients. Because with the point of pole RF, it's very hard to teach people how to do it. It takes years, and we cannot cover the whole population.
If I may add something, Joseph, please.
Yep.
Yes.
Yeah, you can.
Yes, I don't like to hear less experience for cryo. I think that it's not less experience. I think that you are getting the learning curve faster. So you get experience, but faster. I think that it's different. The difference between the cryo and RF, and obviously you know better than anybody, is that RF, it needs more skills. It's longer to do point by point PV isolation. The cryo, it's faster to get the experience. It's not less experience, it's faster experience. This is what I wanted to say. Sorry.
Well, it's an angle of view. I mean, it's for people who have, let's say, who spent less time in EP, and they have maybe less skills, they saw less cases, they can be, they can perform the procedure earlier, and this is the less experience or more experience, the difference.
They get the experience sooner. That's it.
Okay, but for cryo, not for RF, you know, so that's a difference.
Serge, imagine what we learned from Avatar AF. You know, Avatar AF was a study of doing cryoablation versus doing something left atrium with cryoballoon. I mean, you know, because and it showed that similar clinical outcomes. You know, we know that the outcomes were is not measured by ILR or whatever, but still, you know, in the cryoballoon, doing something with cryoballoon is pretty much easy to do something, and it can be effective. So this is the beauty of the cryoballoon, and with RF, no way. You have to have good, quality of isolation because in the vision side, because you're going to have recurrence immediately.
I agree, Ante.
I have one more question for Ante. Is there any data or new data about cryo versus the silent brain emboli? Because you know that in different technologies there was a difference. And there were a few studies earlier, but is there anything from now or with different generations of balloons or with more extensive procedures like ablating on the roof or posterior wall?
So I'll just tell you, I shall tell you data. You know, when we started doing inflation of the balloon prior to inserting Medtronic, and even so with the Polar X balloon, because with Polar X it's so easy to do it, you don't have to warm up your saline, before you can be able to inflate the balloon like Medtronic. But anyway, when you prepare the balloon, you think it's right there, ready for the insertion, and you inflate the balloon, you see a lot of bubbles still on that surface. And I'm pretty much, surprised how small the proportion is of the patients with the SCE after the cryo balloon, knowing this feature. But anyway, we have to take it in mind in contemporary data. Do not go back to 2010, with guided data. Go back to the 2018 with the German centers. Professor Deneke published on that. No matter you use contact force RF or cryoballoon, we are on around about 15 to 18 or 20% of the SCE on a post-procedural MRI for the no matter the platform used, and still for cryoballoon. I don't think, and I think that most of this comes because of the air ingression. Because large sheet, and of course, during the sessional balloon. I think that with extended cryo energy application, it will not go up. I have no data, but it will not go up. I think the most of the SC that for the cryoablation, that you can correlate with cryoablation is due to air ingression, not due to energy delivery. Whereas I'm not sure for RF. For the RF, I definitely see that more RF ablation means probably more SCE with any, let's say 10 or 15 minutes more of RF delivery.
Thank you. So we have to close the discussion. I have a question for everybody, short question, because there is one provocative question from the audience that you said, Ante, that soon cryo might be outdated or replaced by PFA. And I have a question for everybody here. Would you share your personal gut feelings about the future of current technologies? So if we can go from Tim to to Ante.
Okay. I hope so, because we desperately need something which is better. So I hope it lives up to the hype.
So, Jose?
I think that for sure we will improve, but pulse ablation won't be the final solution. I don't think so. In fact, during the ERA Congress, it's interesting, but it will be presented an abstract using pulse field ablation with conventional catheters. So maybe we will move from energies, but the tools will remain. I don't know.
Dr. Yamaguchi?
You're switched off. We don't hear you.
You're switched off.
Muted.
Sorry. I think we need to select appropriate patient for ablation, just a TBI. Probably, I don't think substrate modification improves outcomes based on my histology data. So fibrosis is a diffuse process. So the process to select appropriate patient for PBA only is very important for me, I think.
Okay, Serge?
Freezed.
Serge?
Oh. We don't hear you.
Freezed.
Yeah,
okay.
Freezed and lost the connection.
Yeah. Until Serge connect, I'll just
Like some Thomas.
Okay, so...
Sorry, Serge. Sorry, we didn't hear your answer because it was freezed.
Yeah, sorry, I had a phone call at the same time.
So we know that you are using cryo because you are frozen now.
That's it. No, I was saying that I am a little bit like San Thomas. I believe what I see, and until now, for me, it's a very nice story. I would like to believe, and like said Tim, we need something else. So I hope that it will be better. But I agree also with Jose that we will use the same catheters. And maybe it's. I hope that we will not be disappointed. But again, I want to see it. I want to use it, and then we can speak again.
Okay, Ante.
Yeah, the question was, shall PFA push the cryoballoon away? Yes, I think it will. In 2023, I won't be using any more cryoballoon rather than for the educational purposes, because I think single-shot PFA devices will definitely prevail, and I see no reason why I should be using cryo energy to isolate PVs and cryoballoon itself. So this is my answer, definitely. I'm so positive about it.
So let's see in 2023, I will ask you, or we will see, obviously, how is the development. But in any way, it will be very nice. The whole electrophysiology is very nice, and we are happy that we are part of all this development in the recent 20 years or so. And especially in the last few years, it's really speeding up. And that's why we all do it also. Huh? It's very nice. Thank you for your participation. Thank you for your presentations, for nice cases. And I hope to see you somewhere close from now in a short period of time, let's say, in some congresses, or if not, then next year in Prague, possibly. Bye-bye.
Thank you, Joseph.
Thank you.
Bye.
Thank you.
Hope to see you soon.
Bye.
Bye-bye.